we closely laid off last time was pulmonary embolus. Okay, pulmonary embolus can occur for many different reasons. Okay, most of us associate pulmonary embolus from being a blood clot that comes from the lower extremity, which is a DVT, deep venous thrombosis. The most important component of that wording is deep. Most people think that it's clots from the legs, and that's really not true. Most DVTs that are very, very dangerous and deadly are originating from inside the hip area. Okay, so venous stasis in the hip actually causes more of a massive pulmonary embolus than the ones from the leg. Doesn't mean the ones in the legs don't kill you, but it's less likely. The superficial thrombi that you may see by palpating cords usually are not indicating formation of a deep venous thrombosis. It could be a superficial venous thrombosis. There's also other forms of emboli that can also occur, which we will include in discussion in pregnancy, which is amniotic fluid emboli. You can also get a fat embolus to take place as well. You can also have embolic phenomena from iatrogenic diseases, like somebody actually is putting a wire in you, or there's situations where you can break off a catheter, and then the medical devices can migrate and cause a pulmonary embolus. The pathogenesis is usually a stasis of blood when you're looking at deep venous thrombosis. Okay, so things that will promote problems with formation of deep venous thrombosis will be immobilization. So anything that causes you not to be able to get up and stand, which is a major long bone fracture, femur fracture, tib-fib fracture, anything that is involved with the hip increases the risk. Operative procedures also increase risk. And the reason an operative procedure increases the risk is because you're causing the sympathetic nervous system to be activated, and it causes the clotting cascade to increase, which increases the incidence of formation of more clot. If you have localized pressure to take place, like a tourniquet, it increases the incidence of developing a thrombus. And you can also have venous obstructions that take place. Okay, sometimes hematomas can significantly displace structures like veins and cause the flow to stop in the vein, and then you get a clot that happens after it. So the kind of situation you see in that place is when the hematoma starts to wear off, that's when the DVT throws, and usually it's about a week or 2 weeks after the surgery is done. So I mean, we don't necessarily see, but it can be pretty lethal when the patient's already at home. Okay, sometimes you'll hear about that a patient's died at home after they've survived the operation, survived the hip repair. The patient had lost about 1,500 cc's into their hip fracture, okay, and then all of a sudden goes home and dies from a DVT, PE usually, okay. The other thing that can also alter your coagulation cascade would be anything that increases your density, okay, of your blood. So polycythemia vera, sickle cell disease, those are actually alterations in the red blood cell quality. Anything that increases blood viscosity, so severe forms of dehydration. Malignant diseases also causes a hypercoagulable state to develop in most patients. Pregnancy, recent trauma, and oral contraceptives are also increased risk. If you have abnormalities of the blood vessels, such as local damage, inflammation, you can also get the clots not only originating from a vein or long bone marrow, or like I said, iatrogenic, but you can also have blood clots that leave the actual heart itself. Things like atrial fibrillation or atrial flutter increase the risk significantly for clot to develop inside the heart. If it goes from the right side, of course it causes a pulmonary emboli. If it embolizes from the left atrium, on the other hand, it's systemic. You get strokes and things like that, which we talked about before. Usually blood that embolizes, that returns back to your heart, is going to go to highest perfused areas of the lung. So it's going to go mostly to the right lung. 60% perfusion goes to the right, so you tend to see more PEs going to the right. Okay? Causes a tremendous increase in dead space ventilation that you see as a consequence of that. So essentially it's like main stem intubating somebody. Is it responsive to oxygen? The answer is yes. It's not like shunt. Okay? But the biggest problem is that you have a huge amount of dead space increase. Clinical features is depending on the size of the emboli. If you have a small emboli, you almost don't have any kinds of symptoms at all. It's repeated emboli that can cause prolonged injury, like somebody who's been on oral contraceptives for 20, 30 years, and they've been throwing silent clots slowly. And then all of a sudden they come in at the age of 40, 45, and they have significant pulmonary hypertension. Then you got a big problem at that point. You can't fix it. Okay? So most women like that would tend to pick up by start feeling short of breath. They would say, well, it's just because of my inactivity. They don't sort of blow it off a little bit more. And then you know, they get into the risk factors and developing significant pulmonary hypertension. What you see usually associated with that is not only the person is on oral contraceptives, but it's also smoking. It's a bad combo for a woman. And that increases their risk of these small emboli to develop in that set of population. As for the medium-sized emboli, most people do become symptomatic. Usually they get fluidic chest pain. They get shortness of breath right away, and they do get a very slight fever. The slight fever is anytime you have a blood clot anywhere in your body, you will develop a fever. It's an inflammatory mediated reaction, so it doesn't matter where you get it, hematoma like that, you're going to get a fever, a low-grade one. And that low grade is usually less than 100.4. Okay, so you're looking at 100.2, 100.3, somewhere like that. You're not looking at 101, 102 fevers. Okay, so it's a low-grade fever. Okay, cough may produce blood-stained sputum. That's usually pretty bad. At that point, most people would think cancer right away, but you also got to think about emboli as well. It may also produce a pleural fiction rub, because the inflammatory reaction from the area of the lung that's infarcted may actually then cause a friction rub and inflammation to take place. The chest X-ray often will appear actually very normal, okay? And what it actually picks up is a lung scan. And what actually we're using now to pick it up more so is using a spiral CT scan. Spiral CT scans are much more accurate than lung scans, and it's almost immediate. The results, you have to wait 3 or 4 hours for the results. If you do look at the actual perfusion studies, it'll affect zone 3 of the lung, which is the areas of highly perfused. As a consequence, you get a huge VQ mismatch. What kills most people is a massive emboli. Okay? Massive emboli is what we talk about usually in the operating room, because we pick it up usually very frequently by a rapid drop in end-tidal CO2. The rapid drop of end-tidal CO2 is because there's lacking in perfusion to the lung. Okay? No perfusion, no CO2. Does that mean CO2 is still being expressed out of the cells? The answer is yes. Does that mean CO2 is increasing in the bloodstream? The answer is yes. And also the answer is that the person is becoming increasingly acidotic because of the CO2 cannot be removed. Okay? The other problem that happens is that the left ventricle is dying for volume in a PE. Like you guys did in your workbooks, well, most of you did. Some of you forgot to put the left and right ventricle separated. Okay? The right ventricle is getting too much volume. There's too much preload still in that side. And there's a tremendous increase in afterload, so it can't get rid of it. But the left ventricle is completely empty. So it's a very low preload state, and that's why these people have to maintain adequate volume to return to the left ventricle for you to survive. The only way the heart can compensate for a situation where you get no volume is heart rate. Heart rate's the only thing you can do. So tachycardia is very commonly seen. It's pathognomonic of the disease. Okay, if you see bradycardia with it, you may have something else. Okay, it's very unlikely that you have bradycardia and have hypotension in this kind of situation. You'll be dead if that's the case. Okay, so the tachycardia is the only thing that's going to keep you alive. Usually the right ventricular EKG shows a right ventricular strain pattern. The right ventricular strain pattern is because of the rapid increase in pulmonary pressures. And the ventricle on the right all of a sudden has to increase its load to work on it, and the ventricle tends to get dilated. It stretches the conduction fibers, and many times you can go into a right bundle branch block. Okay? It's about 30% fatal. Okay? And trust me, when you see it, it's immediate. It's the person will tell you, I can't breathe, and be down. And it'll be that fast. I've seen 2 of them people die right in front of me. And both times they knew something bad was happening, and they were gone. There was nothing we could do. Okay, so when this happens and you get a massive emboli, where you get what's called a saddle embolus, which is the next point. A massive embolus is big enough, but a saddle embolus means that the clot literally fills the actual pulmonary arteries at the branch points. Okay, so at that point there is nothing you can do. There is no perfusion going to the lung, and that means there's no perfusion getting to the left ventricle, so you got no systolic pressure at that point. It's immediate. It's very impressive when you see it happen. and it's very quick. Patients don't really complain of hurting. They just go down. Okay? I saw that on a 21-year-old one time and an 18-year-old boy. So it's something you don't tend to forget. Pulmonary circulation is what you see is when that embolus hits. The embolus, a lot of people just think of it just like a giant ball that goes into and rolls into a tube, and then it stops it. Well, it doesn't quite work that way. Okay? If you look at your pulmonary architecture, when it comes out, the pulmonary artery branches into a T. It's one of the few arteries in your body that actually splits at 90-degree angles in two directions. Just think about that. Very few parts in the body do you actually see that. Most arteries in your body always usually branch at a 45-degree angle. The pulmonary circulation, though, branches into a 90-degree angle. And you got to say to yourself, that's a really weird design. Okay? I think that's a weird design because I don't usually see that anywhere in the body. Okay? The reason it's a weird design is most likely is that it's sort of there to break up clot. So if a clot gets pushed in, guess what it's going to hit before it goes to the lungs? It's going to hit the back wall and splatter. And that's exactly what happens. They've actually shown pictures of people with PEs during TEE, okay? And you can actually see it with ultrasound that as soon as the blood clot, which is solid, hits the back wall of the pulmonary artery, it basically becomes like a grenade. It explodes in multiple shrapnel elements, okay? So it becomes microembolic at that point, okay? Which the body can sort of handle. It can handle microemboli, it cannot handle macroemboli, okay? The downside to it is when you take blood that's clotted and you shatter it, what's inside of it? All these hormones, okay? Systemic reaction of anaphylaxis, so SRSA, okay? Thromboxanes, prostacyclines are all being released, which causes like a huge kind of bronchoconstriction effect, okay? Because it's like a histamine release. So these people have extreme bronchoconstriction that takes place, okay, which adds more difficulty to you, okay? And it also takes the lung and squeezes it down, pulmonary hypertension. That's very rapid. It's not so much that every single area has been lodged off by clot. It's because the hormones that have been released cause this effect. So you can get a huge spike in pulmonary hypertension pressures that are very quick, okay? What ends up happening from the increase in PA pressures is that the pressure begins to back up and cause the pulmonic valve to become insufficient, okay? And if that happens, the right ventricle begins to fail, okay? And when it begins to fail, it begins to dilate, so the tricuspid valve begins to fail, which is the same thing you see in a pregnant woman, right? What's the most common valvular abnormality in a pregnant woman? Tricuspid regurg, okay? So because they get pulmonary hypertension too, okay? So they get engorged neck veins, okay, as a consequence of the TR, and they get an elevation in their CVP. It's actually the easiest central line you'll ever put in. And that's how you really pick out if somebody who has a PE. Their neck veins just become so distended that you can actually see them. They just really jump out at you. The first time somebody actually points it out to you, it'll memorize in your memory bank, and you'll never forget it. Because when you see it again, you go like, is the neck veins going up? Oh, this is a PE. Sort of you know pretty quick. Okay? The pulmonary edema that can result is from bronchospasm, is in areas where the perfusion is stopped. It redirects the gas to areas that are more perfused. And thank goodness most PEs go away quickly. And that usually means by quickly under 15 minutes. So your job is to keep them alive for the next 15 minutes. Okay? The worst thing that I've ever seen from a PE standpoint was I was giving this lecture to students at the hospital, and this was like Saturday morning, so I had like a group of 5 or 6 students that I was reviewing this with them, and I get called urgently by the radio to come back to give them a hand in one of the rooms. So I got back in the room, and sure enough, they were doing a hip replacement, and before they did the hip replacement, they still do it every once in a while, they put cement. And when you jam the cement with the actual piece, the metal, it drives the intramedullary pressure of the bone marrow very high, and the cement can extravasate through the veins. So this woman actually had not only bone marrow, but she had cement that went to her lungs. Cement doesn't break down. Okay? So we immediately saw an end-tidal CO2 that dropped very rapidly. Heart rate went up to 130, okay? And we just gave her fluids. We kept her, well volume hydrated. And sure enough, we went for spiral CT and showed that 60% of her lung was embedded with cement. Okay, you figure that's going to get deadly. It's not going to be a good event. What's amazing is that she compensated, and within about 5 days, she left the hospital. Okay, and she still had glue in her lung. Was she perfectly like before she was before? And the answer was no. Okay, but the thing was, at least she was 85 years old, and she got out of the hospital, and her functional capacity had dropped significantly, but not enough that she was noticing it. So, if she was a marathon runner, it would have been a different story. Okay, but at least she got out of the hospital. Okay, so it shows you that most PEs are very transient if you can get them through the first 15 minutes. What kills most people is that first 5 or 6 minutes. If you can't get them through that, then the body can't compensate. What you see from this rapid extravasation of pressure is that some of the fluid will extravasate into the interstitial space, which drops the compliance of the lung. Okay? So the lung compliance drops dramatically, which makes the peak inspiratory pressures on your anesthesia machine rise, which most students go like, why is that happening? They think that, well, it's a PE. I mean, what's happening to the lung? Why is it becoming so heavy? It's because the fluid is backing up and causing it to extravasate in interstitial, and you get almost like a pulmonary edema kind of effect. This will last usually for about an hour or two, okay, and it will start getting better after that once the blood clot gets broken down. Immediately once the blood clot arrives, if you survive the first 15 minutes, the body begins to auto-digest it and tries to reopen the area. It can take as much as 24 to 48 hours to reopen the area completely, but it does eventually reopen it. Okay? If it can't, then it clots off, and then what ends up happening is you end up getting an infarct in that portion of the lung. And that's why you can see bloody sputum when somebody infarcts. Usually it's seen like 3 or 4 days afterwards when the person reperfuses that area, and now the capillaries beyond that are damaged, and the person will start coughing up bright red blood. It's a little bit scary. Yep. It's usually about 24 to 48 hours you see the infarct stage. Okay? And usually in 3 days is when that area will reperfuse anyways in about 3 days, and that's when you get the hemorrhaging to take place. No, because usually medium to large emboli, you notice it right away. People get symptomatic right away. What makes it go away is that the thrombolytic component, which is your body breaks down and clot all the time, will try to break that down as quickly as it can. Okay? Depending on how susceptible you are, if you're a person who smokes and has oral contraceptives and you're hyperviscosity because you're smoking and you're doing 3 packs a day, then your chance of you reopening that diminishes. If you're, on the other hand, very healthy individual, you don't smoke, you have normal amounts of red blood cells in your body, you're not dehydrated, your body's chances of breaking that down effectively goes up. Okay, so it depends on the situation you're in. Our job is basically to get them through it, and most people that you get them through the first 15 minutes do survive. Okay? Do they have impaired lung function? It all depends on how much reserve they had, how many showers of emboli they've had in the past, because some people are chronically doing this, and that's why they develop that pulmonary hypertension. Okay? What you eventually get is you get some, the pulmonary embolus will develop a certain degree of pulmonary edema. You get moderate hypoxemia without really carbon dioxide retention of the person spontaneously breathing. Because one of the things that you'll see the person immediately do, because they have an increase in dead space, is they will do what with their respiratory rate? Immediately increase it. Okay? If you have a person under general anesthesia, though, what will happen? That won't happen, and you will see a CO2 retention. Now, will you see it on your end-tidal CO2? And the answer is no. The reason you won't see it on your end-tidal CO2 is because that's looking at the total amount of ventilation that is not being adequately perfused. So you will have a bigger CO2 gradient between your end tidal CO2 and your blood gas CO2. Okay? After the person starts getting better, you'll see the CO2 come back up and normalize to what it should be. But initially, you'll get a very large difference. Most of this increase is due to dead space. So these people tend to be responsive to oxygen. If you give this person 100% oxygen with basically a pulmonary embolus, they will respond. Okay, as long as they have some surface area of the lung that's okay with the perfusion. Okay, if you don't have any perfusion, then you don't have any blood pressure at that point, so you're dead anyways. But the people that do have some degree of perfusion and pressure, you will tend to be adequately oxygenating them despite losing a large surface area of the lung. Okay? The pulmonary hypertension that can develop can be very high. The normal PA pressures, remember, are around 15 to 20. The main mechanism is the increase in mean airway, the mean pulmonary arterial pressure it could be different causes. One of the things you consider is the left atrial pressures from like mitral stenosis, left ventricular failure. We've already talked about that, so I'm not going to go into that. And then you have the one that we're talking about right now, which is acute increases in pulmonary vascular resistance. Okay? And this is one of the most common causes of severe pulmonary hypertension over the long term for most patients. Now, always when you consider when you got somebody developing pulmonary hypertension, you should have in the back of your mind, are they throwing small embolic phenomena taking place? All right, so this is what you're looking at here. This is the mechanism where you see a tremendous increase in pressures. Okay, you can see vasoconstriction, the backing up into the RV causes tricuspid regurg, an elevation in CVP. So you get the pulmonary hypertension eventually causing right ventricular failure. Okay? What this also will do to you is if you persist for very long periods of time, which usually the PE doesn't persist that long, but if it persists, if it's not getting better, you'll go into liver failure. Okay? So you'll develop coagulopathies in addition to that. Okay? The other thing, your spleen and liver will become enlarged from venous engorgement, from the right ventricle failing, and you also develop increasing levels of peripheral edema. All right, let's go on to the next topic. 3 categories, okay, of actual pulmonary hypertension. There's a vasoconstrictive qualities, okay, and pulmonary hypertension that's vasoconstrictive is usually from something wrong with the lungs, either parasympathetic or sympathetic activation. The sympathetics are going to cause bronchodilation most of the time, and the parasympathetics are going to cause bronchoconstriction. This is weird, right? This is reverse of what it normally will do. Okay, and that's exactly right. The lung tends to follow, to a certain degree, what the brain is doing. Okay? The vasoconstrictive problems that you can get will be receptor dysfunctions that take place at that level. And that's something we can talk about later on if you really are interested in this area. But for now, just understand that there's 3 basic categories of pulmonary hypertension. Vasoconstrictive, obstructive, which is part of this discussion of pulmonary emboli, okay? And then the other one's obliterative. Okay, obliterative can be more conducive to discussion when you're talking about COPD, so emphysema, and you can also have inflammatory reactions like arteritis. It can also induce that, pulmonary hypertension from obliterative disease. And then you have your pulmonary veno-occlusive diseases that occur as well. The primary pulmonary hypertension is the one that's unknown etiology. Usually it's from chronic small embolizations between the ranges of 20 to 40 in the female. Usually the risk associated with that is smoking and oral contraceptives combined. Most people develop dyspnea on exercise and shows signs of right ventricular hypertrophy. Many times they come in with syncope and hypoxemia may occur. It's a progressive disease, but unfortunately it has a very high mortality rate. Most of these people succumbing to the disease by the early 40s. Cor pulmonale is something that is associated with right ventricular heart failure due to pulmonary hypertension. Okay, and this is how most people die from primary pulmonary hypertension. They develop congestive heart failure from the right side, not from the left side. So somebody with congestive heart failure is considered cor pulmonale. But remember, the cor pulmonale is always indicated by the failure of the right ventricle due to pulmonary hypertension. It's not due to any other cause. Now, the other thing that you can see is you can get also what's called pulmonary arteriovenous malformations. Okay? These are found in patients that have liver disease. The reason I talk about this is because every once in a while you'll be taking care of a potential liver transplant patient, and you always have to have in the back of your mind, at least somebody talked to me about it when I was doing my training, of them developing these pulmonary arteriovenous malformations. The patients with liver disease that have developed chronic liver failure do not release adequate levels of hormone, okay, and they get some form of vasodilation that it takes place inside the lungs. As a consequence, you get a significant amount of shunt effects through the lung, and it can become a real problem with oxygenation. If you work in a transplant center, okay, you will actually be doing sedation for patients in the radiology suite, because they'll take these patients and do pulmonary angiographies on them before they do a liver transplant, okay, because about 30% of them have to have coils put in their lungs. Okay. Once they find that they have this arteriovenous malformation, they'll throw little coils made out of metal, they're like springs, and then the area will clot off. Okay. So when you put them under general anesthesia, they'll tolerate it, and then they can tolerate post-operatively so they don't develop these huge shunt fractures, which tend to open when the new liver is put in. Okay? They may not be symptomatic at the time, but they become very symptomatic, especially if you give somebody things like nitroprusside, which increases the nitric oxide levels at the lung level, which opens up these arteriovenous malformations. And that's it on this lecture. I'm going to go on to the next one. Believe it or not, this is the first computer in the United States. Okay? Imagine what you're carrying right now. This had 1/1000th the capability of what you have right now on your laptop. So amazing how much the technology has changed in less than 60 years.